Welcome to Healthcare Forward, where industry leaders, benefit advisors, and healthcare professionals come together and discuss the changing landscape of commercial health plans. Brought to you by Roundstone Insurance, the first group captive for health insurance, where smarter self-funding meets long-term savings. I'm Mike Schroeder, founder and president of Roundstone Insurance. Welcome, everybody. This is Healthcare Forward, and I'm Mike Schroeder, founder and president of Roundstone Insurance. And today we have a special guest from right here in Northeast Ohio, David Sylvan with University Hospitals. David is the Chief Strategy, Innovation, and Marketing Officer, and he also runs UH's Venture Group. And thank you for joining us, David.
Pleasure being here. Love being in Rocky River. Thank you.
Yes, well, we like being here too, and we're new to it. We just moved into this building about a year ago.
I heard you were in a church beforehand?
Prior to that time, we were in a church in Lakewood that was built in 1923, and the building we're in now is built in 2024.
Excellent, excellent.
The church had one big advantage. I was able to tell my mother that I would go to church every day. I'm not able to do that anymore. So, but welcome. Thanks for joining us. So what we're going to talk about today is this idea of smart hospital and AI and how it's impacting how hospitals run their business and provide care. So I think everybody nowadays is talking about AI. So why not us? We'll jump on that bandwagon. All right?
Good. Let's do it.
All right. So the first question I have is this idea of, smart hospitals impacting not only patient care, but the actual operations of the hospital. And can you share what's the difference between the two, or maybe how they're the same?
I think the operations of a hospital represent the low-hanging fruit. Whenever you look to introduce a tool or a technology that impacts patient care or touches the patient or helps the clinician make a decision, the risk bar is far higher. But as you probably know, the hospitals are incredibly inefficiently run. And so anything that we can do to impact the effectiveness, the efficiencies, the waste reduction from an administrative perspective, that's usually the first foray into sort of testing the pipes when it comes to the introduction of new tools, AI or otherwise.
And what do you mean when you say smart hospital? What does that mean?
It means that you are beginning to very carefully orchestrate some threshold of automation or assisted decisioning to tools and technologies. You're taking some reliance off human intuition. You're taking some reliance off human decision-making, and that's why you have to do it carefully. But you're doing so in a manner to increase efficiencies, to reduce error reduction, to take away some of the tedious aspects of day-to-day work.
Now, with AI, it's one of those technologies that I sometimes think you have to be careful with it. And I would guess, patient care is one area you want to kind of move slowly.
Right.
So can you give me an example of how AI can actually work with patient care?
The very early iterations of decision support when it came to AI were probably in the imaging and radiology field. You can imagine that even the native technology on your cell phone, the quality leap from, say, 10, 15 years ago to today, it's almost exponential. And so to use a tool to enable you to affirm a decision that you've made as a clinician, perhaps from as an example, a dermatology perspective, you, the clinician, might have seen, if you're a seasoned physician, thousands of examples of a certain disease state or lesion, etc., over the course of your career. Can you imagine having a digital companion that's maybe seen 10 million examples and is able to affirm your intuition when it comes to diagnosis? Not take over the diagnosis, but really keep the human involved and affirm the decision. That's an example, a very simplistic example of how a tool could be used in the clinical setting.
How far along is UH with implementing some AI tools?
We are very far along. So, just to delineate for a second, US healthcare has been in the AI game for decades and decades. People are confusing, of course, AI with what we now know to be generative AI, the ability for the utilization of large language models to help with decisioning and pattern recognition and the like. So since 22, we've been very actively engaging how we think about the integration of carefully selected AI that would have some type of generative component. We have AI councils, we have clinical councils that all weigh in the adjudication of these opportunities. We've approved 20 generative AIs this year alone, another 10 in the pipeline before the end of the year. It's a pretty active space.
How do you decide of those applications, which ones you scale? Is it a trial and error, or is there some formula for doing that? Because we need to figure that out here at Roundstone too.
Yeah, we see literally, and I'm sure you do, regardless of industry, you're going to see hundreds and hundreds of tools purporting to solve for certain problems. We really start with the problem statement. What's the magnitude of the issue that you're looking to solve? And if in fact you're successful, what type of impact could you have? So we don't necessarily always swing for the fences, but the problem statement's got to be sufficiently meaty, and that usually then drives us towards how we'd source against that problem statement. So some could be very specific to a clinical department or disease state. Some might be macro, impacting, for example, patient experience. So and everything in between starts with the problem.
At Roundstone, we've been trying these AI tools for the last several years. And one of the takeaways we have is there's, even on the ones that fail, that we decide that they can't really help us and they're not something we can apply across the business. We learn by failing. Is that a shared experience with you? I think almost like, because what we find is a lot of these AI tools, these AI consultants, they tell you they can fix it. They tell you can do it, but they don't really know your business the way you know your business. And it is not until they get in and try that we find out whether it's going to work. Is that a shared experience?
You can't go straight to production in healthcare unless it's a proven tool that's been utilized and tested and affirmed elsewhere. So we usually do everything on a trial type basis. Start with a proof of concept or a pilot. Make sure that you're hitting your marks, you're doing no harm. Carefully define the measurables, the milestones, to make sure that you can do the look back to see if you're impacting the problem statement. I hate the term fail forward or fail fast. Fail fast actually has value. Fail forward, I think, is a bit of an excuse sometimes. So I tend to hope that the way in which we design these interactions, these engagements, enable you to pivot well before you reach a fail point. You'll never bat 1,000, but try to obviate that risk.
Now, I know from being a person in Northeast Ohio that UH has been in this innovation space, has been trying new approaches to healthcare,
Yep.
whether it's AI or anything else, and that's part of the job that you have. What is that? Why does UH have that kind of culture or that approach?
UH is almost 160 years old. So the notion that we needed an innovation department is folly. It had always been an innovative organization and remains such. What it didn't have was this central enablement mechanism, this platform that could wrap resourcing around some of the most promising ideas. And that's truly what we set out to do. We have a dual focus. We look at our own intellectual property, what we can spin out of our research mechanisms, our administrative domains. People are obviously always solving for problems that they face. How can we put mechanisms around them to see if there's in fact a there, if there's commercial viability? But we can't solve for all of our own problems. So we've created this top of the funnel, if you will, this sourcing to enable us to look outwardly for opportunities, usually in the early stage space, that we can bump up against these problem statements. Look at about 400 of those a year. Do something with a very discrete subset thereof, but you have to do a lot of filtration. You have to kiss a lot of frogs.
That's right. Roundstone is recently starting to look at startup companies. I think the fancy term they use is venture capital fund,
Right.
and looking at, when we do that, we look at what challenges we have within our business and then look for those solutions out there that we feel that could help with that challenge.
Right.
That's kind of a chicken and egg type question. Is that how UH goes about it, or do you do it differently?
If we had our druthers, that's the only way we would do it. Unfortunately, we can't stop that sort of unsolicited intake, the stuff that comes over the fence without any curation, the stuff that comes through, and we love them, that comes through board members or prolific inventors internally, these physicians who are subject matter experts. They're always going to be solicited, and that's why you need a mechanism in place to ensure that you can catalog, you can categorize, you can quickly disposition if in fact it's not something that we want to be able to work on. The last thing we want to do is have to spend a lot of time and a lot of people's valuable energy focusing on a myriad of opportunities when some of those are candidly bridges to nowhere.
Yeah, it's it's funny how close we're experiencing the same thing, and you have to learn how to say no politely. And one of the areas that is, I'm sure you're familiar with AI as insurers that we see a lot of is there's lots of AI tools as it relates to prior authorization and how they go about that. And that's one of those areas that's patient care in a way. And so you have to be very careful at how you do that and not do it the wrong way.
That's right.
'Cause it'll have a pretty dramatic negative impact
That's right.
if it was. So, um, how did you get to this place where you're innovating at a hospital?
Um, Absolutely not by design. My background is boringly public accounting. No disrespect meant to my friends who are public accountants, but it was not something that I wanted to stick with. So I jumped into something ridiculously different, and that was professional sports. And I was with a company called IMG for about 10 years. That's what brought me originally from South Africa to New York to Cleveland, which is where IMG was headquartered. And spent about 10 years in that space doing some of the M&A work, doing some of the treasury work and the foreign exchange hedging, and working in team sports and motorsports and some very, very interesting areas. And then I had an opportunity to join an investment bank, to truly skip industries again. And I joined an investment bank. It was at the time known as McDonald and Company, McDonald Investments. It was acquired by KeyBank and became packaged as KeyBank Capital Markets, the broker-dealer. And I spent a number of years in the derivative space, running the derivatives platform, a fixed income platform known as public finance, which is tax-exempt paper issuance. And about 10 years ago, about 12 years ago, stepped off that treadmill, stood up my own consultancy practice, began teaching at Case, and doing my own early stage investing as an angel. And I had a small consultancy practice, and this client came along, this hospital system that wanted to start an innovation platform. I stayed for 6 months and then never left. Fell in love with the mission and realized that not coming from healthcare, although I can't say that anymore, but not coming from healthcare initially was actually a benefit. It enabled me to perhaps ask the silly questions, why do we do it that way? And I was given a lot of latitude, and I'm grateful for that, to be able to hire folks, many of whom do not come from healthcare but have distinct design backgrounds, to continue to ask that why do we do it that way type of question. And that's been a differentiator for us compared to perhaps other healthcare systems who have their own embedded innovation or venture capital arms.
Yeah, you're saying something that very much resonates with me. One of my favorite sayings is, if you want to learn something about your business, hire someone who knows nothing about your business,
Truth.
and you'll get some insight there. And you also mentioned someone who was a big influence on myself. You mentioned IMG and Mark McCormick. I, like Mark McCormick, I'm a recovering lawyer.
Right.
So I remember reading his book and saying to myself that there is a better way.
What they don't teach you in
Yeah,
Harvard
right,
Business School.
right. I don't have to stay in these crazy law firms, and I could do something different, much like he did. And he was a very successful fella at what he created. Can you share one of your favorite AI or innovation tools that you're working on now, or have applied, or that you're real excited about?
Boy, there are many. We have some recently published success stories. There was a thesis that we didn't always need a nurse in the room from a patient care perspective. At times that is cost prohibitive. It might be inefficient. It might not have that nurse who's trained to a certain threshold working at the top of his or her license. They might candidly be sitting and watching the patient who might be exhibiting, say, falls risk or delirium, etc. And so we partnered with a company known as Vital Chat to determine if we could integrate virtual nursing into workflows. The thesis would be that the patients would be satisfied with this sort of digital connectivity, this tethering, but we had to test it out. And we did in a very careful, orchestrated sort of concentric circle model. And we discovered that families and patients actually really did like this modality of two-way connectivity via, think of an iPad on wheels, so to speak. They felt that they were always connected with their caregivers. They understood that they were interacting with a bot and with an AI, but meds, discharges, care planning, assessing falls risk, this was all happening automatically. We've now gone to a hospital on our east side, and it is the first fully staffed virtual nursing hospital in the country. Obviously, there are still humans in the mix, but each room now features this virtual connectivity, and early returns have been excellent. Patients enjoy the ability to seamlessly communicate with their caregivers. We're able to reallocate resourcing to their best possible use. So there's an asset resourcing allocation opportunity. And we are putting care back in play, ironically, because nurses are now able to spend time engaging with patients face-to-face versus being consistently forced to have to document or code or chart, etc. So it's just a great opportunity for us.
Yeah, I think that's an example where the care is improved, the efficiency is improved.
Exactly.
It's kind of hitting both goals.
Exactly.
I'm a big fan. That MyChart tool. I recently went to an executive physical over the course of 2 days. I think I had something like 18 appointments.
Right.
And it was all done, through that app. With very little human direction. I may have gotten lost once or twice,
Right.
but I managed to hit all the appointments, so that's great. I do think folks are now ready to accept that.
I think you're right as well, and especially a younger generation who is always digitally tethered via some modality, and many would report that they actually like the modality that they would prefer from a care delivery perspective is digital where possible. And so we're sort of leaning into that.
So a lot of folks, and certainly in today's news, you hear about how healthcare, the healthcare system is broken. What's your view on what's causing some of the stresses in the healthcare system?
How long is the podcast? Just remind me.
We got about 5 minutes.
Okay. Some of this is sins of the fathers. We do it in a certain way because we've always done it that way, and we've not necessarily heeded the opportunity to learn the efficiencies and the process improvements that other industries have already had to solve for. We also have a very convoluted financial model. Our revenue, our reimbursement comes via the insurance, the payer mechanisms, if not self-pay. And there's a lot of striation when it comes to the differentiation between how much you pay, where you receive that care, what your means might be, what your entry point to the system is. And so you end up with the probability of redundancies and inefficiencies and the lack of uniformity one site to the next, as an example. So it's multifactorial. I believe that by most measures, U.S. healthcare is still the best in the world. But unfortunately, if in fact your outcomes are going to be the best here versus anywhere else, it's equally true that you're more likely to need healthcare in this country compared to other countries. And mortality, you won't live as long in this country. It's a conundrum. Best healthcare in the world, and yet the outcomes are possibly not there to reflect that. So a lot of us are all leaning into how we eat the proverbial elephant one bite at a time.
I think also too, it would help if folks get a real good understanding or definition of what they mean by best. Because I agree with you, when it comes to the care, it's hard to duplicate the care you can get in the United States. The quality of the care and the technical resources is second to none. But I think sometimes when people get in these debates, they kind of define best to be like expensive or it's more costly, so it's not as good. And those are really two different discussions,
Right.
cost and quality. And, when you pull them together, you get value. But I'd be interested, and I'm kind of going off script a little bit from the outline our folks gave us, but it's something that I've really dove in pretty deeply is, we recently had that law change on the transparency where the government said, we want you to publish your what your prices are but it's with the networks. And there's a new piece of legislation that's recently been introduced where they said, that's fine, but we really want you to publish what you would take in cash. If it was point of service, point of sale, what is that number? I was wondering your thoughts on that.
It's a bit of a slippery slope because you create this, you further increase the wedge and the divide between those who can and those who can't afford healthcare. And we, as by some measures, the most industrialized jurisdiction in the world, should be in a position to provide high quality and affordable healthcare to everyone. It's a nirvana state, certainly, and there are models all over the world that you can claim may or may not be optimized or optimal. I think the notion of delineating different access by virtue of ability to pay by cash is a bit of a slippery slope, and I might be a bit of an outlier in that regard, but I think that does create a further divide from an access perspective.
Yeah, to me, I like it because I think it makes, at least and I'm in commercial insurance, so we don't have government pay programs and
Right.
But at Roundstone, trying to cause the members and the patients to become consumers of their health care, I do think that the cash price would help with that. It would encourage behavior to look and see, hey, this is a high quality provider, and the cash price is within the realm of reason.
So a nudging, if you will, for those who can.
Almost everything else we buy, we know what it's going to cost. And so why don't we give that a try with healthcare? I share your thing with the divide between those who can afford it and not. But at the end of the day, that's really about the funding mechanism for those different populations. I think both, whether it's government funding mechanism or the commercial funding mechanism, could benefit from knowing what is the cash price. And being an old accountant, you might know that cash flow is pretty important, even at a hospital.
Well, time to cash recognition, absolutely. And this is one of the only industries, to your good point, where cost of goods sold is still an ephemeral threshold.
Yeah. Well, you're talking to one insurance guy that would like to get you your cash at point of service. So keep that in mind. I do think that's something. As I mentioned, we are jumping into this innovation game ourselves, and it's focused on insurance. And I'm wondering your thoughts on that. Is that a worthwhile endeavor?
The healthy, at times, animosity and disdain between payers and providers is a gap that has to be narrowed. And the only way to do that is through co-innovating, co-design of programs or opportunities to perhaps obviate the time delay between prior authorizations, approvals, denials, and then, of course, cash recognition. It also puts the patient in a position where their experience improves because they're not having to focus disproportional amounts of time on wondering if, in fact, they can afford their healthcare, if there was more of a seamless relationship between the payers and providers. So big fan of collaboration to close the gap between the two.
Yeah, member satisfaction and member interaction. make it simple.
Right.
Those are all worthwhile objectives. I think that both organizations share.
And AI might be able to help in that regard. We're
Certainly.
certainly seeing a lot of effort on both ends of the spectrum to build tools to speed that process. We're not there yet, but there's work.
Yeah, that's one of the AI tools we're looking at. Is there's so many variations of employers' plan designs, where the benefits are different year to year and employer to employer. And people don't find out a lot of times until after they have the experience with the
Right.
provider. So one of the AI tools we're looking at is to make those more closely aligned, so
Right.
that you're not, just because you changed your insurance provider, you're not also changing some meaningful plan designs without knowing.
Right.
And we feel that AI can help in that area. But that's good for the provider too, because providers put in the position of delivering some bad news that something is not covered the way the person expected it to be
Right.
covered, so.
Got to deliver bad news really quickly and really sensitively, but it's got to be in place beforehand.
That's good.
Yeah.
I'd like to chat a little bit about the future state. What does it look like with innovation and AI in, say, 10 years?
I wish I knew, because I'd be very long those positions. But I think what it looks like is we have begun to wash inefficiencies and waste out of process. We are delivering care where the patient wants it, in the modality that they demand. They're seeing the provider that they wanted to see, and they're getting the care at a price point that they can attain. One of the only ways to do that is to wash inefficiencies out of the process, and that's where technology can come into play. We also will put ourselves in a position where we're delivering care without dependence on bricks and mortar. So the physical plant will no longer become the rate limiter, the determinant of where care is delivered. And we all know that care is continuing to transition to the ambulatory and outpatient space. And in some respects, some elements of that care is going to continue to transition into the virtual space. And so I think in 10 years, you're going to see a lot more efficiency from the perspective of hospital operations. Unfortunately, you're probably going to see fewer hospitals as well, because there is a price point to be able to attain those types of efficiencies, and not everyone's there. We could get into what legislation might do to impact that positively or negatively, but we know that's a wave that we're riding. We can't really control that at this point, but we have to predict and preempt and begin to position ourselves. So those are the things that excite me, this notion of attained efficiency when it comes to care delivery.
Yeah, we really like and endorse that virtual approach. We're always looking for cost efficiencies, and we've seen it go well beyond just telehealth, and we're seeing virtual care and things like MSK rehab and mental health.
Right.
And we're supporters and advocates for that, because we think that the cost efficiency is while maintaining the quality as well,
Right.
and the access is all improved by those type of
That's right.
innovations. So yeah, I'm glad to hear you say that.
Right.
So.
And care is going to move to the home as
Yeah.
well, in a more pronounced way than it is now.
Well, that's good. That way my kids won't be throwing me in a nursing home real soon. I like that. All right. So if you were going to talk to another provider, another hospital system, what would you tell them about innovation and how UH has effectively done so well in creating this strategy of innovation?
I think it sounds cool to sort of set up a skunk works in a basement with 2 beanbags and a Labrador. You're going to fail. What you have to do is ensure that you have got support and patient support at the highest thresholds before you press go. So that usually implies some type of commitment at a board level to enable you to have the time to begin to reap some rewards. This is a patient-long game. The return horizons on innovation, certainly the return horizons when it comes to early stage capital deployment, those take a long time, and you're going to bat 100, and that might actually be pretty good. So I would say the primary advice would make sure that you have sufficient patient air cover to give yourself as an organization time to let the season settle and then reap some rewards.
I have to say, as we dip our toe into it here at Roundstone, sometimes it almost sounds too good to be true. In that I look at some of the returns and the track record of success that others share and advertise, and the skeptic in me wonders whether it's real.
The skeptic in you is astute because they're not advertising the misses and the fails. And the early stage capital deployment road is littered with those that thought there was a quick win to be had there. We don't view the capital we deploy into the early stage as an answer in and of itself. It is an enablement. It enables us to keep our innovation, our culture of innovation alive. It enables us to experiment with cutting edge tools, perhaps solve the problems that they're designed to solve. It helps us with an internal engagement, but the pure cash-on-cash return, if you will, is not the primary focus. We have that second and third bottom line of measurement. Did we impact the problem, and/or did we perhaps facilitate, clinical trial and discovery work? So we have a more broadly defined latitude when it comes to how we define return.
I'm thrilled to hear that, because at Roundstone, our objective is more about finding those solutions that help our business and help us deliver the already effective solution we have. We're trying to make it better.
Yep.
And if along the way we don't lose our shirt,
Right.
we'll be happy. But we really are. That's not the driving force. So,
Right.
So that's great. We share and agree with you on that.
Great.
David, so I'm sure some folks are listening and saying, wow, this sounds pretty technical, and David's an incredibly intelligent fella, but what does this mean to me? And so I guess the question really is, if these things go well and we see the efficiencies created by the work you're doing with innovation, and maybe that includes some AI, what does success look like for the patient?
Switching costs are very low now for patients. Patients now have choice. Patients want a more retail experience when it comes to the consumption of healthcare. There was a point in time where we were price takers. We as patients had no choice. We needed to see a physician, a doctor, a specialist, or generalist, and we got what we got. And what that usually included was robust wait times, inefficiencies when it came to scheduling, completely incomprehensible instructions when we left, and an inability perhaps to understand completely what had happened during that encounter. Patients don't want that anymore. They want simple ease of use. They want the Apple experience. They want the Ritz-Carlton experience when they're consuming healthcare. Now, granted, the former two are by choice, and the third, healthcare, might or is invariably not by choice. But the extent to which we can put the patient into a consumer mode versus a taker mode, I think that's what success looks like. I got the healthcare I needed, where I needed it, how I needed it, and at a price point that I could afford, and actually understood what was happening during the encounter. I think that shouldn't be a very high bar, but that's what we're aiming for.
Yeah, I would think that the efficiencies would cause more patients to say, hey, I got what I expected, or I received, this was easy to understand. I followed what occurred here.
And the humanity piece. I actually was with a provider who displayed and revealed that they actually cared about me. Mm-hmm. And a lot of that is effectuated by just looking at me. Mm-hmm. And right now, and of course we're looking to perfect this with ambient listening, providers usually are facing away from you and they're facing a keyboard and they're listening and they're being attentive, but they're not really engaged to the extent that perhaps we were used to growing up with the doctor who came to visit us at home. And we need to bring that humanity threshold back. And the irony is, technology can help us bring the human back to healthcare.
Yeah, I would think so, because a lot of times the reason they're not looking at you is they're typing in
That's right.
data into a system. And if you can do that in a more effective way, and they can actually start looking at you and finding out who you are and what you look like, and that would be great.
I was asked to give a presentation. This was a few years ago, and I said, "That's great. Do I bring slides? What am I supposed to do?" This was for an organization out of town. They said, "You have 17 minutes." Well, I thought that was an odd number. 15 minutes or 20 minutes or half an hour, 17 minutes. I didn't understand the time allocation. Their premise was that's the average amount of time a physician can spend with each patient. That's the amount of time we're going to give you to actually, to tell your story. So we need to change the experience of time. It might still be 17 minutes, but if I'm facing you as the provider for the entirety of that time, we've actually created time through that engagement.
Yeah, we just had a conversation on this podcast with an organization that provides what they call direct primary care, where it's a subscription model, and they allot 1 hour of time for their patient encounters. And so I, reflect on the last time you spent an hour with a caregiver.
Right.
But certainly at the primary care level, that changes things. That's a game changer. So if technology can help give yourself some more time,
right,
that's a win.
Exactly.
And for patients, that's what success looks like. Right. So is there anything I haven't asked you that I was supposed to, or you'd like me to ask you, or anything like that? And
I think we're at a fascinating juncture in healthcare where we could be we could represent the edge of the spear in terms of really this integration of technology and human, where that would enable us to really think about things like personalized healthcare, the N of one when it comes to bespoke healthcare plans and treatment plans that are very specific to your individual state and condition and needs. And that's very difficult to do currently, the way in which we're structured, and technology can help to perhaps parse that a little bit with a little bit more rigor. I think incredible opportunities in speeding time to the drug discovery timeline, which we know is debilitatingly expensive and very long with a lot of failure points. And that would also narrow the divide from a cost perspective. If we can dramatically accelerate the time to proof or failure when it comes to a new molecule, I think we would all be the net beneficiaries, and technology is going to be our friend.
Yeah, I'm excited. We like it. We like the path that you're going on, and we like the path that we're pursuing as well. And
Right.
as long as we share that objective of quality, affordable healthcare for all, which I don't know if you know that, but that's the mission of our company, and we try really hard to make that happen. And
well, affordable and attainable does not necessarily imply a quality degradation. You can achieve both.
Yeah. Interesting enough, one of the things I share with folks is one of the greatest, for all the problems or complaints you might have about the healthcare system, usually if you chase quality, you also get value.
That's right.
It's one of the things where it's not counterintuitive.
No, it's not.
And if you go out and you try to find the best, usually there's value connected with it.
That's right. That's right. Amen to that.
Well, I appreciate your time today, and thanks for visiting with us, and I enjoyed the conversation.
Likewise. Thanks for having me.